Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. Again, many patients coming to your clinic asking about the role of omega-3 in pregnancy. Should they use it routinely or not? This is the target of this lecture, to give or not to give routine omega-3 in all pregnant ladies or not. We have to highlight some basic information quickly. What's omega? Functions of omega-3 and obstetric benefits of omega-3. You know that fatty acids and fats are either saturated or unsaturated. Saturated with hydrogen ion, and this is solid in room temperature, and this is not helpful because they are increasing the low density lipoprotein, increasing insulin resistance, and decreasing fertility, as you can find in the lecture on omega and fertility, both in male and female. Also, trans fats are not good regarding fertility and body functions, which are hydrogenated oil, became solid at room temperature. We are focusing on the unsaturated fatty acids, no hydrogen ion, and these unsaturated are essential for the body functions. And they are liquid at room temperature and containing double bond between the two carbon atoms. And this may be one double bond. This is called monounsaturated fatty acid, which is omega-9 is the famous type, or more than one double bond between the carbon atoms, which is polyunsaturated fatty acids, can be omega-3 or omega-6 fatty acids. Why called omega? Because it is the position of the final double bond in the chemical structure, which is for omega-3, it is 3 carbon atoms from the omega, which is the tail of the molecular chain. Others here, omega 11, 4, 7, and so on. So we have omega-3 and omega-9 polyunsaturated, and omega-3 and 6 polyunsaturated. Omega-9 is monounsaturated fatty acid. Omega-9 is of little importance in pregnancy. Actually, they are helpful for protection of the cardiovascular system, decreasing low density lipoproteins. They are not very useful for the body because they are found in the body and found in vegetarian food. Now we are focusing on two important types of omega-3 and omega-6. Both of them compose the cell membrane of the cells of the body, and they are bioactive lipid mediators and provide source of energy. They are competitors. So omega-3 is anti-inflammatory, omega-6 is pro-inflammatory. So omega-3 is super useful and it cannot be made by the body, while omega-6 is pretty useful and actually has a role in immune system and stimulation of immunity. This is good for to have pro-inflammation in the body, but if increases, this increases the risk of inflammation and inflammatory diseases. So from this figure, we can see that we have to have balance between the anti-inflammatory and pro-inflammatory types of omega-3 and 6. If omega-6 increases, inflammation will increase and harm will occur in the body. This is the clinical impact of this figure. And also this algorithm shows that we have 3 types of omega-3 according to the number of carbon atoms, and it can be 22 carbon, DHA, 20, which is EBA, or 18, which is ALA. Here you can see that omega-6 and omega-3, as I told you, are competitors, anti-inflammatory and pro-inflammatory. This leads to relaxation of blood vessels, for example, improving circulation, relaxing muscle spasm, reducing blood clotting, and decreasing pain sensitivity, while the reverse in cases of omega-6, which is usually plant origin. Regarding the 3 types of omega-3, we have ALA, which is vegetarian coming from plant origin, but it can be converted to DHA in less than 5% and to ABA in less than 20%. So the body should have the DHA and ABA from other sources than the internal conversion from ALA. And actually, these two types are the most therapeutic types of polyunsaturated fatty acids. They are called long-chain omega-3 threes and suppress low-grade inflammation by omega-6. So the omega-3 comes from some fatty tissue, particularly oily fish, krill oil, and algae oil, okay? While omega-6 comes from some vegetarian sources, vegetable oil, sunflower oil, meat, poultry, eggs. We have to stress on DHA and EPA. Why? You will see now. DHA and EPA come from marine origin, which is fish origin, cold water fatty fish. This is a source of DHA and EPA. They are essential. They should be acquired from diet, cannot be synthesized from the body. Just few percentage is converted from ALA. So the normal individual should have good support or good intake of diet that contains omega-3, DHA, and EPA. And this comes from low mercury, cold water, fish, like salmon, shrimps, sardines, and mackerel. But if the patient is not eating these types of food, being vegetarian or vegan, the source of omega-3 comes, DHA and EPA comes from algae. So he or she should eat algae oil or algae to have the source of omega-3. But marine source is more rich in the fish. The second basic point, what are the functions of omega-3? From this introduction, you know that omega-3 forms the cell membrane, phospholipid of the cell membrane. So it's important for the whole functions of the cell and introduction of all material to the cell. And this is the basic function of the fatty acids. There are competition. There is competition between omega-3 and omega-6 on the same site in the cell membrane. They are very similar in chemical structure. And so the body should have good amount of omega-3, not less than the amount of omega-6, because if there is deficiency of omega-3, the omega-6, which is pro-inflammatory substance, can predominate, so the inflammation will occur. Another function of omega-3, of course, it is anti-inflammatory, as I told you, increases blood flow, alters prostaglandin biosynthesis, important for embryo implantation in the uterus by decreasing the pro-inflammatory prostaglandins from the omega-6 and increasing the anti-inflammatory prostaglandins, which are prostacyclin and prostaglandin F3 alpha, while omega-6 increases prostaglandin E2. Actually, it is an antioxidant, so it is an anti-inflammatory and antioxidant because it goes inside the cell and stored in lipid droplet and released to go inside the mitochondria and help in ATP formation in addition to coenzyme Q10 and pyruvate, as previously mentioned in previous lectures. So in short, it is an anti-inflammatory, antioxidant with increasing blood flow and good for implantation. But this is a common finding in most of the supplements or nutrients during pregnancy. anti-inflammatory and antioxidant. What is the new for the omega-3? The new is that omega-3 is fat, so it is a major construction of the brain and retina. 97% of all omega-3 fat in the brain and 93 in the retina. So DHA is peculiar for development of the brain and retina of the human being. And here comes the importance of the intake of omega-3, DHA and EPA during pregnancy, particularly in the third trimester and even after delivery, up to 18 months of life. So what are the obstetric benefits of omega-3? From this previous slide, you can see that is important for fetal brain development, for fetal retina development, as a role, anti-inflammatory and anti-preventing abortion, antioxidant, important in determining the length of gestation, prevention of perinatal depression of the mother and child's subsequent neurodevelopment. So deprivation of omega-3 fatty acids is associated with impaired development and behavior scores. So it's recommended that during pregnancy, the ladies should have DHA in their diet and by different means to decrease risk of preterm birth and early preterm birth before 30 weeks, and also to decrease risk of very low birth weight in pregnancy. And there is a strong evidence that using or eating the sources of DHA and EPA or DHA alone would decrease the risk of preterm birth by 11%. And a recent expert review found that adding extra dose for patients with low level of omega-3 would significantly decrease preterm birth and early preterm birth in randomized controlled trials. And this umbrella review actually highlighted the importance of omega-3 in prevention of preeclampsia, low birth weight, preterm birth, post-term depression, and some improvement of immunologic immune system and visual activity in the infants, and cardiometabolic risks decrease in the pregnant mothers. But some studies did not find any relationship. Also, increasing EPA and DHA would minimize the risk of type 2 diabetes mellitus, especially those with increased serum triglycerides, and may decrease the risk of some fetal problems, neurodevelopmental problems, asthma, autism, and other studies found some relationship to these diseases with omega-3 intake. And omega-3 balance to omega-6, if impaired, increasing omega-6 would increase risk of miscarriage, preterm birth, and initiation of labor in some studies. As I told you, because this is pro-inflammatory and this is anti-inflammatory, by increasing inflammation, increasing omega-6, the increased prostaglandins that lead to inflammation and muscle contraction would lead to abortion, will lead to preterm birth, while increasing prostaglandin, omega-3 would increase prostaglandins that lead to relaxation of the muscles. Now we come to the main target of this lecture, which should routine omega-3 be prescribed in pregnancy or not? Before answering this question, we have to take care of three issues. Number one, we have to pay attention to the patient's diet, identify the high-risk patients, and monitor serum omega-3 level. We have to pay attention to the patient's diet. We have to give the patients enough time in the clinics, asking about the diet. Is the patient eating Mediterranean diet or healthy diet or Western diet. You know, Mediterranean diet is full of vegetables, fruits, whole grain, olive oil, nuts, and so on. Now, also, these issues, vegetables and fruits and so, are taken every day, while while fish and poultry and yogurt, eggs are taken twice weekly at least, and with less fat, with less hydrogenated fat, with less saturated fat, with less meat. So if the patient is eating this healthy type of food, this is good. This means that she has a source of omega-3, and usually if she is eating at least twice weekly fish, so she may not have a deficiency of omega-3. While the patient on Western diet was full of fat, full of chocolates, carbohydrates, sugar, trans fats, this patient is at risk of having omega-3 deficiency. So the first point in your clinic is to pay attention to the patient's diet. If she is eating Western diet, you have to advise her to avoid this type of diet and go to more healthy types of diet like Mediterranean diet. Because the Western diet is poor in omega-3, particularly DHA. Number two, if she is eating Mediterranean diet, we have to advise her not to increase diet containing omega-6 because it is pro-inflammatory, and increase diet that contains omega-3 because the balance should be 1-to-1, which is one of the advantages of Mediterranean diet. But if she's eating Western diet, the balance is impaired, and the omega-3, omega-6 ratio is 1-to-17. And actually, in practice, some studies found that most of the people are eating a bad style of omega balance diet, which is omega-3, omega-6 ratio 1-to-20. So also consider avoid omega-6 diet like vegetable oils and processed food, which are not good for the health. So number one, pay attention to the type of diet. Prefer healthy diet, Mediterranean. Number two, minimize omega-6 containing diets to keep the balance. Number three, here are the oil of the omega-3, for example, flaxseed, canola, shea, a pumpkin, soybean, these containing ALA, and regarding DHA and EPA, this animal source or the plant source is algal oil. While omega-6 oil is sunflower, the cottonseed, corn flour, these are not good source for omega-3. They are good for omega-6. We don't need more omega-6 because this is a pro-inflammatory and is not good for the pregnancy. And mind you that many ladies come to the clinic, say, we are eating healthy diet with olive oil. Olive oil is good for health of the heart because it contains omega-9, but is poor in omega-6 and omega-3. So it is good for the heart, not for the pregnancy, the brain and retina of the baby, and continuation of pregnancy. This is another important practical point. Okay, she is eating fish. Which type of fish? Are you eating white fish? You have to change from white fish to oily fish, which is oily fish. And here, the oily fish, you have to eat the flesh, the meat of the fish, not the liver of the fish. So if she is eating fish, white fish, change it into oily fish. We have to highlight that she has to eat oily fish, as I told you, salmon, shrimp, tuna, and so on. And this should be the flesh, which is the meat of the fish, and oily with low mercury content. That's why she has to eat two servings per week of seafood. Why two? Only two, not more, to avoid mercury toxicity. So it should be the flesh of the fish, not liver, because liver contains vitamin A. And should be oily fish, not white fish, and should be twice weekly, not more than twice weekly to avoid heavy mercury. So there is a scientific base when you instruct your patient to eat. The type of fish should be oily fish, the flesh of the fish, and at least and not more than twice servings per week. As I told you, liver contains excessive vitamin A, which is not good for pregnancy. Excessive fish lead to mercury toxicity like other metals, and this is not good. So when to start diet rich in omega? While you are counseling your patient, you have to start it as early as possible with the onset of pregnancy. The second point to take care is identification of the high-risk patients for omega-3 deficiency problems. Who are at patients are at risk of the problems of omega deficiency? They are patients who are having history of recurrent pregnancy loss, high risk of preterm birth or early preterm birth less than 34 weeks, with previous history of depression, history of fetal neurologic problems, neurodevelopmental or visual problems. As I told you, the brain and retina are mainly by DHA. And here, a study showed that patients at high risk of spontaneous preterm birth with decreased cervical length, increased cervical vaginal fetal fibronectin, and other biomarkers are in bad need of excessive omega-3 and additional dose in the second trimester, not later than 20 weeks, up to 30 weeks is given. Why up to 30 weeks, not later? Because excessive omega-3 after 37 weeks leads to prolongation of pregnancy. Here are some studies explaining the mechanisms of omega-3 in prevention of recurrent pregnancy loss. The third point to put in mind before answering to take or not to take omega-3 supplementation is, are you monitoring serum omega-3 or not? If you have a good monitoring in the serum, this is good to avoid excessive omega-3 and avoid some side effects of using it. So some doctors do not give omega-3 routinely for all pregnant ladies. Why you don't do? Because it is a fat, and it is not like water-soluble vitamins, which if given in excess, they go to the urine. So it is fat. It may have some accumulation in the body and have some risks. This is number one. Number two, excessive consumption of omega-3 fatty acid has negative effect on the immune system and may inhibit blood coagulation, as mentioned in all studies. Also, the omega supplementation may have some digestive issues like nausea, indigestion, diarrhea, fishy aftertaste, allergic reactions, smell, fishy smell, and sweet. High level of mercury can negatively impact the development of brain nervous system. So why to take the source of high mercury? And actually, it has been reported that only 3 out of 32 fish oil supplements in the markets contain pure and of good quality DHA and EPA. And methyl mercury cross to the placenta and serious effect of nervous system has been reported with excessive omega-3. Why to give excessive omega-3 if the patient does not have deficiencies? This is the argument of this team of not giving this supplementation. And to avoid this mercury toxicity, you can go to vegetable oils like algal oil or flaxseed, shea, and others, and not more than 2 servings of seafood. And if you are obliged to use supplementation or to give supplementation, you have to go to high quality purified supplementations. And there have been some reports on the adverse effects of excessive omega-3, like increased risk of large for gestational age babies, increased risk of post-term pregnancies. That's why it should be stopped at 37 weeks. And this is a recent study. Actually, it is a cost of the patient, pregnant ladies, to give her iron, calcium, fatty omega, and other products that are some costs on the patient, and the patient become pregnancy is a physiologic phenomena, and the patient becomes a diseased person with a lot of medications. So these are the arguments of the team who are not recommending giving the omega-3 as a routine to all pregnant. But there is another team that recommends giving the omega-3 to all pregnant. Why? Because approximately a quarter of women during pregnancy are not getting the recommended amount of omega-3 as mentioned in some reports. But in this study, which is a recent study, found that patients who eat fish, only 13 of them consume fish twice weekly or more than twice weekly, which means good source of omega-3. 22 consume it once or twice weekly, 40% less than one time per week, and a quarter of them never consumed fish or consumed it less than one time per month. So there is a common deficiency of the source of omega-3 from diet. And there is evidence that prenatal period is a time of increased risk of omega-3 deficiency. And marine oil supplements are often recommended to pregnant women to fulfill their requirements as recommended by WHO. Again, WHO mentions that recommendation of a minimum of 200 to 300 milligram of DHA per day or up to 1,000 during pregnancy should be put in mind. And pregnant women with one baby should have at least 500 to 1,000 milligram of long-chain omega-3s every day from 12 weeks, and at least 500 of DHA per day as reported in a Cochrane review. It's safe. These mentioned side effects by the team of non-giving are minimal and not common. It's safe. And if we are giving supplements, they are fish oil and not fish flesh. And this is devoid of mercury. And if we use algal derived DHA, this is more safe, no mercury toxicity. And also, old reports of increasing bleeding, particularly in patients on anticoagulants. This study found that on a study of 8 clinical intervention studies, there is no bleeding-related adverse events and no effect on the coagulation parameters, even with high dose and even with prolonged use of the omega-3. It's not cost if you buy a supplement, because the cost comes if the baby is delivered preterm, if the patient has abortion, if the baby has neurologic problem, has visual problem. This is the actual cost, and this is the burden on the public and community, rather than talking about the cost of the capsules, which is not too expensive. If we give supplements, what are the recommendation? Early, you can use it from the beginning of pregnancy with low dose up to 100 or 120 per day, but starting from 12 weeks, you should increase, according to WHO, to 200 to 300 milligram per day for brain and eye development. And if the patient is at risk of preterm birth or early preterm birth, you have to add additional dose or supplements to up to 1,000 milligram DHA and EPA or DHA alone from not later than 20 weeks and not later than 37 weeks to avoid prolonged pregnancy. In all cases, should stop after at 37 weeks to avoid prolonged pregnancy. And a take of 1,000 milligram of DHA or alone or DHA and EPA is important and does not raise safety concerns in the general population, as mentioned in this recent publication. And high dose is more important and more effective than low dose in this randomized study. So in conclusion of this talk, we have to take care that omega-3 is important. It is the main construction of the brain and retina of the human being in intrauterine life and after birth. So take care of omega-3 fatty acids due to its importance for baby's brain and retina and prevention of preterm labor or birth as proved in many studies. But before giving supplementation, you have to assess dietary intake by screening with few questions. Give your patient more time to ask about the type of diet. Should be Mediterranean, should avoid omega-6 oil, should avoid imbalance in the omega-3 6, and regarding fish, should change from white to fleshy fish and avoid excessive fish, and so on. So this is important. Also, we have to search for a practical screening approach to identify ladies with a deficiency of long-chain omega-3 fatty acids, and we have to search for standardization of laboratory methods to assess the levels in the blood. And if we are giving supplements, we have to search for purified, high-quality forms to avoid the side effect of excessive mercury, and avoid 3 points: fish liver, avoid overdose, avoid late use. These are important last recommendations. Thank you.